صباح الخير. You know it's too early. أنا نفسي I'm struggling إن إحنا نصحى كده ونفوق شوية. Anyway, all right. Just like we heard right now from Dr. Sami about cachexia, it's a very common syndrome, like he mentioned, in many disease states. حتى في America, we don't only see it in cancer patients. We see it in COPD, HIV, and whatnot. So we're going to talk about the treatment options from a pharmacological point of view because I'm a pharmacologist, so we have to talk about that. So, treatment and supportive care. When we think about cachexia, we are not supposed to only think about pharmacotherapy. Pharmacotherapy, there are many options. We're going to see many drugs right now. Mirtazapine, megestrol, acetate, Garland, steroids, and whatnot. However, very important to pay attention to the non-pharmacological aspect. How do you do this? Because sometimes الأدوية مش كلها هتشتغل. Sometimes there's going to come a point where there's pharmacological treatment are not working anymore, are not giving you the response that you're looking for. So paying attention that talking to the family, whoever is taking care of the patients, is to prepare their favorite food. Talk to the family about what do they like. It's not about quantity anymore, it's also about quality. So not necessarily eating a lot, even if it's small meals, but it's what actually they like, what they actually enjoy. Sometimes even these patients, they have swallowing problems, they have dysphagia, they can't swallow the food. Sometimes we have them chew on it, get the flavor. That's also something, you know, that they could benefit psychologically from. Not necessarily eating, but just the psychological aspect of it. Also the social benefits of eating at the dining table, eating together, not isolating the patients like Dr. Sami talked about the social consequences. Making sure that we're eating with them, sitting down, having conversations and whatnot. Small, frequent meals. It's not about quantity again, it's about small, frequent meals. So on the same time, they're not experiencing nausea and vomiting and whatnot. And very important also to ensure optimum mouth care so they don't have mucositis, fungus, and whatnot. Also providing a relaxed environment, avoiding strong food, heavy, spicy, no molokhia, no hamam, all this like big heavy stuff that's hard to digest, like easy stuff for the patients. In terms of pharmacological options, if you look at the guideline, there's no one, like what we call it, there's no one cap that fits all. It's basically pretty much tailored among the patients. Everyone will be different. A particular drug may work for a particular patient, it may not work for another one. So a lot of the treatment is focused on talking to the patients and the family. Very important to include the family, because like Dr. Sami mentioned, احنا السوسايتي بتاعتنا في مصر ما بياكلش خلاص هو بيخس عشان ما بياكلش ضعفان and all this stuff. So very important to explain to the family that cachexia, it's an irreversible condition. Very, very important. Setting realistic goals. Telling them this is secondary to the fact that they have cancer. The cancer is incurable. Now we're shifting goals to focus on comfort, to focus on quality, to focus on what matters. And to explain to them that no matter how much we feed them, they're not going to gain weight again, right? They're not going to get the muscle they're losing. They're not going to get up and go to work and whatnot. Very important to set realistic goals. And to also explain to them that this is an uncommon symptom. It's different from starvation. We're not starving the patients. We're not letting them die. It's just the fact that they have this active cancer going on right now that is eating their body, just like the picture Dr. Sami showed us earlier. So, when we think about cachexia, عشان نفكر نعالجها, لازم also to think about what other causes might be some reasons the patients are not eating. Maybe there are differential diagnoses. So differential diagnosis, maybe they have a certain medications on board that's causing them to be anorexic. So things like digoxin, theophylline, for example. Maybe they are depressed. A lot of patients are depressed, they will not eat. But we could misinterpret that, it's cachexia. Meanwhile, it's a psychological issue, so we need a psychologist or social worker to work with them. Maybe late life paranoia, maybe they have swallowing disorder, they have head and neck cancer, they got a lot of radiations, maybe they have mucositis, they have fungal infections. Maybe they also have dementia of some sort, so they're developing dementia-related behavior. Maybe they have other comorbidities like hypothyroidism, hyperthyroidism, that could also cause you to not eat, hyperthyroidism in particular. Maybe they have malabsorptions, like cystic fibrosis or malabsorption of some condition. Maybe they have low salt, low cholesterol, and whatnot. Maybe they have gallstones that's causing them to have discomfort, so they are not eating, so they're losing weight. And we're thinking this is related to the cancer, but it's not related to the cancer. So the point is, when you see someone who's losing weight, لما حد بيجي في الأول, is you're doing a differential diagnosis to try to fix whatever you can fix before you make that firm diagnosis that they have cachexia. In terms of treatment, pharmacological options, there are many options on the market. There's megestrol acetate, there are famous glucocorticosteroids, there's mirtazapine, we'll hear from Dr. Catherine later about it. There's dronabinol, there's anabolic steroids, there's cyproheptadine, thalidomide, L-carnitine, Gurlin, Dr. Sami will talk about, celecoxib, and fish oil. So just very quickly, I'm going to go over each one of them. megestrol acetate هو أكتر حاجة بنشوفها. I'm pretty sure حتى في أمريكا it's the most commonly prescribed medicine for cachexia. It's a steroid derivative. It's a synthetic derivative of progesterone. So it acts as an anti-inflammatory. Like Dr. Sami mentioned, this is a chronic inflammation going on in the body. So if you give an anti-inflammatory of some sort, it protects the body from the damage. It's approved by the FDA for the treatment of anorexia and cachexia or unexplained significant weight loss in patients with AIDS. However, one important thing to know about megestrol, that doesn't work right away. It takes time to work. Usually it takes 8 to 12 weeks to see benefit. And this is a trick right now. And this is where family don't understand. The trick is, even after 12 weeks, the weight that the patients will gain is not muscle mass. It's not what they lost. It's a steroid. What is it going to do? Puffy. Water retention, right? So the family looks at them like, they're putting on weight. No, they are not. They're just keeping water retention. They're just gaining water. They're not gaining what they're actually losing. So if you look at the studies, it tells you if you give megestrol for 12 weeks, and the patient comes back, and the patients or the family come back and tell you, I'm not noticing any difference in their appetite, it's recommended to actually discontinue. You will not see any benefit after 12 weeks. There are many randomized controlled trials that looked at megestrol acetate, in particular in cancer patients, also in COPD, because we do see cachexia in COPD patients, that supports the use of megestrol. However, for me, or for many clinicians, and maybe Sami would agree with me here, that it's a drug that has a lot of also toxicity and side effects, and a lot of the side effects are dose related. The higher you go up on the dose, the more likely you will see the toxicity. And in particular, we're worried about thromboembolic events, PEs or DVTs. Patients who have cancer, they are hypercoagulable to begin with. So this is actually a drug in cancer patients that we try as much as we can to stay away from, believe it or not. It's not our first line option, because especially patients who have cancer, getting active treatment, getting chemotherapy, they might have, hypercoagulopathy problems, getting DVT or PE, so you have to be very careful using it. But if someone doesn't have any predisposed risk, you can take it. The maximum daily dose is 1,600 milligrams per day, and it does, it's a steroid, so the effect definitely causes peripheral edema, hyperglycemia, and whatnot. The trick is, again, it doesn't work right away. And when we say work, patients will ask for food. They're not necessarily going to open the fridge and eat everything in the fridge. They're just going to have that sense of wanting to eat more. Another alternative is corticosteroids, very commonly used also for the treatment of cachexia. In 2005, there was a systematic review of 6 blind randomized control studies of different glucocorticosteroids, dexamethasone, prednisone, methylprednisolone, and whatnot, that showed that corticosteroids overall improve the quality of life and appetite. But again, they have the same issues like megestrol. They don't affect muscle mass. They don't do anything for muscle mass. They just give patients that sense, عايز ياكل أكتر، حابب إنه يسأل على الأكل, but not necessarily eating a lot more, not quantity. That just sense of like euphoria or being happy or asking for food. The biggest issue in cancer patients when we talk about glucocorticosteroids, especially if they're getting active treatment, chemotherapy makes you myelosuppressed, increases your open window for opportunity to grow infections, neutropenia, fungal infections, and whatnot. So we cannot really use glucocorticosteroids chronically for patients who have cancer, and especially getting active treatment. Also, the other issue with glucocorticosteroids, that there is no optimal dose defined. And this is a classic question. I don't know if you get that question, Sami, or not. Patients or oncologists will ask, what dose, how long, how much? There's no defined dose in terms of glucocorticosteroids. Is it 5 milligrams of prednisone? Is it 2 milligrams of dexamethasone? What dose should I use? But I can tell you from clinical practice, we usually, when we give it for cachexia, 2 milligram twice a day. You can do 4 milligram twice a day, but I don't need to go to like 16, 18, 20. I'm not treating like spinal cord compression. I'm not giving it for chemo prevention. So low dose, and even the maximum that we do in clinical practice up to 10 days. After 10 days, if the patient comes back and tell us, it didn't make anything, it didn't differ, مش باكل أكتر, مش بسأل أكتر and whatnot, we just discontinue because long-term toxicity also of corticosteroids. Another option is cannabinoids. In the States, we have actually a medicine called Dronabinol. What are cannabinoids بالعربي? Hashish? Hashish, oh, okay, right. All right, great. So you have it here in a different form, which is sort of, and you know what? Even in America, patients actually will prefer to smoke it than actually take the actual capsule, Dronabinol. They will tell you, no, I want to go out, I want to smoke it. Sure, why not? If it helps you with your appetite, I don't have a problem with that. Like even we tell them that all the time. But in America, it's actually available in a capsule form called Dronabinol, which is FDA approved for weight loss, in particular in AIDS patients. It's not approved for cancer patients. And there is one comparative trial that published with cancer patients looking at which one is better, megestrol or cannabinoids, in terms of like weight gain and in terms of appetite, and said that when you do both, بياخد hashish and at the same time take megestrol, they do better in terms of that sense of well-being and asking for more food and whatnot. But again, no effect overall on lean body mass. Anabolic steroids are another options. They're more common, I would say, in Europe. In America, we don't really use them. They're pretty much common in Europe. The Endocrine Society has published many clinical trials in their clinical practice guidelines for replacing testosterone in chronic illnesses, especially for men who have hypogonadism, such as like men who have HIV/AIDS or type 2 diabetes or end-stage renal disease or POD, but not in cancer patients. So giving like testosterone therapy to replace has shown to increase lean body mass. It sounds promising, but we need definitely more data, in particular in the cancer patient population. Cyproheptadine, it's like an antihistamine. It's like taking diphenhydramine. It's similar structure to any antihistamine, loratadine, citrazine. And the whole idea is antihistamines, you know, they work on the histamine receptors, they make you a little want to eat. However, the biggest issue with using antihistamine, that they make you sleepy. Exactly, so you have an elderly patient that you want to recommend antihistamine for them, for appetite stimulant, but at the same time it makes you sleepy, affect you and whatnot. They're pretty much common in children. Cyproheptadine is a medicine we use a lot for children who has cancer in the United States. But the biggest issues with it, again, also just like all the ones we've been discussing, no effect overall on the body weight. It is. Okay, cyproheptadine exists in Egypt. That's what someone told me. I think I شفته في 57. I saw it in 57. Okay, yeah. So it exists. It is an option. You know, there's a very old trial that was done back in the 90s looking at using cyproheptadine in metastatic carcinoid tumor. Supported its use in terms of improvement of appetite, but again, no effect on the lean body mass. We have not seen to see something yet that affects the lean body mass. And then we have thalidomide, which, you know, it's an anti-tumor drug that's used mainly for patients who have brain tumor or multiple myeloma, exactly multiple myeloma patients. It's a potent inhibitor of TNF alpha production. It was studied mainly in patients that had TB or HIV infection. It has shown some promising data, possible role in cancer patients, but when we think about risk and benefits, am I going to give someone thalidomide and worry about the extreme toxicities from thalidomide as a chemotherapy for cachexia? We never use it in clinical practice. The toxicities are horrendous. Talking about peripheral neuropathy, talking about sedation, you're talking about thrombocytopenia, you talk about myelosuppression. It's not worth it as a point of view from like clinical perspective, risk and benefit. Amino acid or L-carnitine. L-carnitine is an amino acid, you're sure you know that. It's required for the transport of fatty acid to the mitochondria where they are utilized to generate metabolic energy. It's mainly used to give energy, to improve the energy. It's not necessary, again, for the weight. There's a randomized control trial of using L-carnitine up to 4 grams. It was a small trial, only 72 patients who had pancreatic cancer, advanced pancreatic cancer. who reported after the use of L-carnitine up to 4 grams per day an increase in their body mass index, an improvement in the overall quality of life, and the trend towards improvement of survival. But again, the N is very small to generalize the statement to walk around recommending L-carnitine for everybody. But speaking to many nutritionists, even here in Egypt, they do recommend it. I see some people agreeing on that. They do recommend it as a supplement, 4 grams once a day, only 5 days per week. Celecoxib, which is an NSAID, non-steroidal anti-inflammatory. There was a small placebo-controlled pilot study of cachectic patients, cancer patients using 200 milligrams twice a day. It was associated with weight gain and increase in body mass index and improved the quality of life. However, it was also a small study, and NSAIDs used in cancer patients is very controversial because a lot of times chemotherapy makes you thrombocytopenic. You don't have platelets. Patients are also cachectic. They're very small. We're worried about falling and breaking a bone and bleeding under the skin and whatnot. So it's very controversial looking at that, using it, but it is an option. And then I guess the last one is fish oil supplements, which stimulates the adenylate cyclase activity and lipolysis, which is the whole mechanism of cachexia part of it. However, the evidence remained to be extremely inconclusive on cancer-associated cachexia, and there was a Cochrane database meta-analysis that concluded that there is again insufficient evidence to walk around and recommend fish oil for the treatment of cachexia. This is important to know. Why? Because you will see family coming to you telling you, oh, what about fish oil supplements? What about celecoxib? What about L-carnitine? And the evidence does not support its use. It's costly, it's not cheap. Patients have to pay out of pocket, so think about this. Think about what you really need. Maybe they just need more frequent meals. Maybe they just need to smell the food. Maybe they just need to chew it and spit it, rather than focusing on like things that doesn't actually provide any kind of benefit for them. And investigational, Sam is going to talk to us about that, and Berlin. And artificial nutrition support, and I do have my second talk to talk about feed or not to feed, and what do you do with the ethical controversy on exactly controversial. But there's no evidence overall to support artificial nutrition, any kind of like TPNs or NG-tube or PG-tube, especially in patients who have advanced illnesses, right? We're not talking about someone who's getting active chemotherapy and they're not eating. Of course, you need to support them, give them TPN, give them supplements or whatnot. We're talking about people who are terminal, hospice, expectancy of life is 6 months or less. These are the patients that there's no benefit in doing this and doing that. Only you do that in certain cases, like patients have high-grade bowel obstructions or malabsorptions from advanced cancers. However, even to do that, they have to have good function status. So the palliative performance scale has to be like 70% or above. Colonoscopy score have to be 70% of enough. They don't have to have any other comorbidities. They have good function status overall. So in conclusion, cachexia is a core clinical features of many advanced illnesses. It's not something like Sammy mentioned we only see in cancer patients. Oftentimes it goes undiagnosed, unfortunately, because oncologists are only paying close attention to chemotherapy, radiation, cure. It's a silent also symptom. Patients don't necessarily verbally talk about they're not eating because they're very overwhelmed with their cancer and many other issues. Feeding is not the answer, right? Especially in advanced illnesses. And there are many pharmacological options that we just talked about right now. It's always about risk and benefit. It's not one size fits all. You know, maybe minestrone will work for another patient, maybe something else, ciprofloxacin will work for one patient. So tailor it around the patients and their performance status and life expectancy and whatnot. And that's pretty much it. Any questions? No? Dr. Sandy? Should we take the questions at the end, or? Okay, I guess, yeah, like a panel or something.